Today we're going to talk about Doppler, and we're also going to talk about some of the ultrasound controls on a machine. For our basic ultrasound machine controls, one of the controls is our Grayscale Maps. And on an ultrasound image on the monitor, you'll always see a grayscale bar on the side of the monitor. And you remember that ultrasound is based on brightness of the little dots on the screen. And each dot represents an echo returning from the tissue in the body. The stronger the reflection from the echo when a sound wave hits something in the body, the brighter the dot that returns to the ultrasound screen. Ultrasound is made up of various shades of gray, all the way from whites to blacks to lots of different shades of gray in between. And you have the option on an ultrasound machine to change what we call the grayscale map. And this just means that a map picks how bright the overall shade of each shade of gray is. In the lab, we use the GE machines. On GE machines, generally you have a choice between one of several maps, anywhere up to 10 different maps. On our picture here, all of these are different choices, and all the Grayscale Maps, when you switch to different maps, is doing is it adjusts the shades of brightness of each shade of gray. So it determines how dark or light each level of the white, gray, or black is going to be displayed based on the strength of the echoes. It can give different color representation slightly to the strength of each echo. Another control on an ultrasound machine is called dynamic range, and I get a lot of questions about how does a grayscale map differ from the dynamic range control. The dynamic range control, we're going to go more into that in a bit, but that increases or decreases the number of gray shades that are displayed by the machine, where the grayscale maps adjust the brightness of each of those shades of gray. So how those two controls differ. We also have the ability on machines to do color or tint maps, and the color or tint maps can be applied to the overall image itself, or it can be applied to spectral Doppler waveforms. And why we use these sometimes is our eyes can really perceive slight changes better by adding color to things. If you're trying to find something very subtle or looking at a waveform pattern that's very subtle, by adding color to it, that enhances our eyes' ability to be able to see slight changes. The machine has the ability to change to many different colors. So you can have, oranges and pinks and blues and reds. So there's many options available. Doppler is a really important part of ultrasound. It basically lets us determine blood flow within an area. There's three main types of Doppler. We have power Doppler, spectral Doppler, and color Doppler. And we're going to go through each of those and talk about when we use them and why. But basically, what Doppler does is it compares the frequency that is transmitted into the tissue by the transducer versus the frequency that's received back to the transducer. And a shift in frequency can let the machine determine what direction things are moving. So it actually looks at the motion of the red blood cells in the blood and determines are they moving towards the transducer or away from the transducer, and also how fast they're moving based on this measuring this shift in frequency. We call the transmit frequency, that's what the frequency that goes into the tissue and encounters a moving object such as red blood cells. And then the frequency that is reflected back to the transducer, we call that the received frequency. So they're measuring the difference between the transmitted frequency and the received frequency. And a shift in Doppler shift, is when there's a difference between these two frequencies, when they're not the same. So when you have a really large Doppler shift, or a really large difference between the transmitted and the received frequencies, that is dealing with higher velocity flow. When you have a really small Doppler shift, or a small difference between the transmitted frequency and the received frequency, those are low velocity flows. A positive Doppler shift. This is where an object or the red blood cells are moving towards the transducer. So the frequency that is going back to the transducer, or the received frequency, is going to be higher than the transmitted frequency, or the original frequency that was sent out. And this results in a positive Doppler shift number. Negative Doppler shift, exactly the opposite. This signals to us that the object is moving away from the transducer. So this is where the received frequency, or that frequency that's coming back to the transducer, is lower than the original frequency that was transmitted out. This gives us a negative Doppler shift number. The three types of Doppler are color Doppler. We also call this CF for color flow. And color Doppler measures the direction of flow. It tells us whether it's a positive or a negative Doppler shift. It also tells us velocity information by assigning a color to different speeds and directions of flow. Power Doppler is our most sensitive type of Doppler. And rather than measuring a difference in frequency or a frequency shift, power Doppler measures the strength of the Doppler signal rather than a shift in frequency. So it lets us pick up little tiny amounts of blood flow and slow flow. Spectral Doppler, this is where we put a little sample volume or a little measurement caliper in the middle of a vessel. And within that little tiny area, we can pick up information about blood flow. So it gives us the speed and the direction and all of those things by giving us a waveform that tells us directions of flow, velocity of flow, and also the pattern of the blood flow. Each vessel in the body, both veins and arteries, are going to have a different blood flow pattern or a different waveform. So we can tell whether or not the arteries and veins are moving in a normal direction and at a normal rate and speed and type of flow, or if there's disease present. All right, so what do the colors on the color map signify? So first of all, we look at our baseline. Our baseline here is our black area, our area of zero flow, and that's where there's not going to be any Doppler shift. Colors above the baseline, often this is set as red, although that color can be easily switched around. Any color above the baseline is considered our area of positive Doppler shifts, or flow moving towards the transducer. Flow that's moving away from the transducer is represented by our color below the baseline. These are our negative Doppler shifts. The brighter the color, that's our higher velocity flows. The darker the color, this is our lower velocity flow. And then you can have a mosaic of colors. This is where you have mixed velocity. This could be an area of vessel narrowing or an area of aliasing. Important part of our color Doppler control is the color gain control. So just like our grayscale controls, gain that can make the whole image brighter or darker, color gain works on the same principle. It can make the entire image have more color signals or less color signals. And this amplifies the Doppler shift signals or decreases the Doppler shift signals. So when we turn up our color gain, we're allowing more Doppler shift signal to come onto our picture, and when we decrease our color gain, just the opposite occurs. So how do we set the correct color gain? So we want to bring up our color box, and then our color box, when it comes up, will show our color Doppler signal. And we want to turn the gain knob all the way up until we start to see noise in the image. And noise is all these extra color signals that don't represent true color flow. When we see noise, we then want to turn our color Doppler gain signal down just until the noise is gone and we're just getting normal color signals. And that's our correct color gain level. So the color box is the screen, the little box that pops up when the color Doppler control is turned on, and anything within that box can show us the color Doppler signals. Color invert is a key that we press, which changes what color is represented on our flow towards the transducer or flow away from the transducer. So when you press invert, it switches the red and the blue around. And always look to see if your invert key is pressed. breast because it's important to know what color is representing your flow towards the transducer and what color is representing your flow away from the transducer. Color noise, these are extra signals in our color box that don't represent true areas of flow. This can be caused by either artifact, like such as patient motion or a patient talking, or by our color gain being set too high. The velocity scale. So on the color Doppler map here, we have colors assigned to velocity. So the brighter the color, the higher the velocity. The darker the color, the lower the velocity. The further away from the baseline in either direction, the higher velocity flow that you're going to have. Then we're also going to have a number at each end of the color scale here, and that represents the velocity range. So the range of velocities are going to be displayed on that color map. And you can change that range of velocities by changing the PRF or the scale control on an ultrasound machine. Color bleed. So this is an artifact. This is when in a blood vessel that the flow is spilling outside the walls of the vessel. And usually this just means that your color gain setting is set too high. Transducer pressure and color and power Doppler. So one of the most important things in breast imaging is that we use very little transducer pressure when we're evaluating blood flow in the breast. The reason for that, in the breast, the blood vessels are very tiny, and the smallest amount of pressure really collapses or obliterates those vessels. So it's very important to keep minimal transducer pressure and really lighten how much pressure we're using whenever we turn on color or power Doppler in the breast. Aliasing. So aliasing is flow that is changing speed or direction. This can either be due to vessel dynamics, such as narrowing, or improper color settings. And what this appears as, instead of your normal colors, it appears as multiple colors within a vessel or blood flow. Now this can be artifactual. It's artifactual when we've reached the Nyquist limit, and this is when blood flow has exceeded the Nyquist limit. Nyquist limit is the limit of velocities that the machine can pick up. So if our PRF control is set incorrectly, you can get artifactual aliasing, but it can also represent true velocities, such as when a vessel curves or it narrows, and this is when blood flow can become turbulent and increase in velocity. So causes of true aliasing would be vessel narrowing, which is called a stenosis, vessel branching, sharp turns in a vessel. These are, the curvatures of the vessel, or if we're using Doppler angles that are too high, above 60-degree angles. All right, so our PRF, this is our pulse repetition frequency. So ultrasound pulses are transmitted at a certain frequency. The number of pulses of sound that occur in 1 second is known as the PRF. This ultrasound PRF, also known as the scale control, it increases or decreases the range of velocities that the ultrasound machine can pick up. So on that color Doppler map here, it increases or decreases the range of the velocities of that number there. The Nyquist limit. This is the maximum limit of Doppler shift that can be measured by the ultrasound machine. So Doppler has a limit. It's not unlimited. Past the limit, the ultrasound machine can no longer measure the velocity of flow because it gets too high. So above the Nyquist limit, aliasing is going to occur. So if the range of velocities you have on set is too low, you're going to get aliasing. And the Nyquist limit is always going to be half of the PRF. All right, power Doppler. Power Doppler is a control on an ultrasound machine, and this measures the strength of the Doppler signal returning to the transducer rather than the shift in frequency. So the strength of power Doppler is it can pick up small vessels and really slow flow because it's so sensitive. So it detects the presence or the absence of blood flow. It cannot pick up flow velocities, and it cannot tell direction of flow. But the downside of it is it's so sensitive that it's oversensitive. So it's subject to color flash artifact. And color flash, it's a motion artifact. It creates all these artifactual echoes within the power box. It can also happen with color Doppler, but less often. And this is most of the time due to patient motion. Spectral Doppler. So this is another Doppler control in an ultrasound machine. Excuse me. And it's going to collect Doppler information from a very small area known as the sample gate. So within that little sample gate, it demonstrates the flow characteristics of an area. So the flow direction, the flow speed, strength, and it projects a waveform pattern that lets us know how that vessel is flowing. We call it a spectral tracing or waveform pattern. And each vessel in the body, arteries and veins, have a characteristic waveform pattern. So if there's any deviation from that expected pattern, that can represent pathology within an area. There's two types of spectral Doppler. You can have continuous wave or pulsed wave. So these are the two types of spectral Doppler. We have continuous wave Doppler and pulsed wave Doppler. So the best way to illustrate how these two types of Doppler work is by talking about the ultrasound crystals. And an ultrasound transducer has many crystals, but we're just going to pay attention to one or two crystals within that row of many crystals just for illustration purposes. So remember, as we're talking about this is happening all the way down the row of that a line of crystals, but I'm going to focus on one or two of those crystals at a time. So for continuous wave Doppler, we're going to talk about two crystals. So there's one crystal that's sending a signal and one crystal right next to it that's receiving a signal. So the signal's always going to be on because you aren't having a crystal wait and listen for the echo to return because there's one crystal that's always waiting for it and one crystal that's always sending it. So one crystal sending and one is always receiving. And what this type of Doppler can provide us is a waveform tracing. So it can be an audible signal or on graph paper. So it gives us the Doppler sound information or a tracing, but it can't form an ultrasound image. In order to form an ultrasound image, you need to have pulsed wave Doppler. And this is where you have one crystal, and the same crystal both sends and receives the signals. So the signal is on, off, on, off. So it's on when it's sending, it's off when it's listening. On when it's sending, off when it's listening. So you have the sending time plus the listening time for each crystal. And the crystal can't do anything, it has to wait to get the signal back before it can transmit another pulse. Now this is the type of ultrasound that can produce an image. So not only our grayscale image, but also our Doppler image. So you can have a grayscale ultrasound image, a power Doppler image, a color Doppler image, or a spectral Doppler image, all based on this pulsed wave Doppler. With increasing depth, the time it takes to go round trip is going to increase, and the crystal is going to have to wait longer for the signal to return before another pulse can be sent out. All right, so spectral waveform. So this is just breaking down all the parts of the spectral Doppler. So on our spectral Doppler here, you're always going to have your color map on the side, and you have your flow above the transducer or moving towards the transducer, and your flow moving away from the transducer. Same thing with our spectral waveform tracing. There's going to be a baseline, which is this line here. Flow below this is flow moving away from the transducer. Flow above this line is flow moving towards the transducer. So any parts of this waveform above the line are flow moving towards the transducer. Any parts of this waveform below the line are flow moving away from the transducer. The further you get away from this line in either direction, the higher the velocity of the flow, either a positive Doppler shift or a negative Doppler shift. So our positive Doppler shift would be above the baseline. Negative Doppler shift would be below the baseline. We have what's called our sample volume. This is what comes up when the spectral Doppler is turned on. So you get your color map that comes up, and within that color map, you're going to have this little waveform tracing. And you put that in the middle of your vessel, and this lets you measure the signal or get this waveform down here on the screen. Antegrade flow. This is forward flow. So this is flow that's moving in the expected direction in a vessel, flow that's above the baseline. Retrograde flow is the opposite. This is flow that's moving in the opposite direction as is normally expected within a given vessel. This is our flow below the baseline. Velocity scale. So there's going to be a scale on the side of our waveform tracing, and this is going to show us the flow, how fast it's going in centimeters a second. And this range of velocities that the scale is set to pick up can be increased or decreased. So you can have for higher or lower velocity flow volumes. We have our sample volume. This is also called our spectral gate. This is the little tiny area where the flow signal is measured within. Spectral Doppler invert. So you can press the invert key, and this is going to change, just like our color map changes above the color that's represented by above or below the baseline. This changes how the waveform is getting picked up on that color map. So pressing the invert key while color and spectral Doppler are on changes both the color Doppler map and the spectral waveform scale. The invert key changes the color that is assigned to the positive Doppler shifts and the negative Doppler shifts on the color map. The invert key also flips the velocity scale on the spectral waveform tracing. So it will display the negative Doppler shifts above the baseline and the positive Doppler shifts below the baseline. So how we tell what we're looking at on that is you want to look at the baseline and figure out if there's positive or negative Doppler shifts above or below that baseline, and that will let you know if your invert key is on or not. Doppler angles. So these are really important in when we turn on color Doppler. So when we turn color Doppler on, first we get our color map that comes up, our color box, and that lets us have color flow within the signal or within the vessel. So we'll say this is our vessel here. We're also going to get a line, and there's a little sample volume attached to that line, but we're also going to get an angle, and we want our angle that comes up to match the direction of our flow. So here's our angle signal that's going to come up. Angles from 0 to 60 degrees are going to be our most accurate angles, so they're going to provide accurate Doppler shift information. When we get angles above 60 degrees, these are our 61 to 89 degree angles, you're going to get errors in velocity. So it's going to over or underestimate the flow velocity. The larger the angle, the greater the error that's going to occur. So an angle of 0 degrees is always ideal. So 0 degrees would look like this. But that's very difficult to obtain. An area of 90 degrees provides no flow information, so you can't measure a Doppler shift at 90 degrees. All right, so the next thing we're going to talk about is duplex and triplex imaging. So this is when we're using more than one type of Doppler at the same time. Duplex imaging means that you have your grayscale image up, plus you're going to turn on spectral Doppler at the same time on the ultrasound screen. Triplex imaging means we're going to have our grayscale image up, plus we're going to use color Doppler on top of that, plus we're going to use spectral Doppler. So it just means basically you're using more than one type of Doppler at the same time. All right, so just a little bit of information about arteries and veins is what we're going to go into next. So arteries are the vessels that take the oxygenated blood from our heart and our lungs and move it throughout the body. Arteries are going to be pulsatile. Generally, the flow is going to be above the baseline for arteries. And arteries are going to have three basic flow patterns: triphasic, biphasic, and monophasic. Arterial flow is generally above the baseline, antegrade flow, and pulsatile. And The arterial waveform is divided into phases based on the contraction and relaxation phases of the heart, so systole and diastole. So here's our arterial waveform here, and the first half of the waveform represents systole, flow during systole. Second half of the waveform represents flow during diastole. So what pulsatile means for an artery is this means that the blood flow is moving through the vessels at a variable velocity, which is dependent on the beat of the heart. So it's a rhythmic beat, it's a pulsation. And this flow velocity is going to accelerate and decelerate based on this cardiac contraction, the heart beating. We also talk about resistance. Resistance is factors that impede or slow blood flow. The resistance that blood experiences when it travels through the vessels. So as blood flow travels through the vessels, there's resistance on these vessels. The good thing about arteries is they can change their resistance, and they change how much resistance is to an area in order to divert flow towards area in the bodies that need it most. So arteries are always going to either have a high resistance or a low resistance pattern of flow, and this is how much resistance is going towards that vessel. So with a high resistance arterial flow, it's more pulsatile. So this is our high resistance flow here. And high resistance flow is found in our extremity arteries and areas of the body that don't need constant blood flow going to them. This is a more pulsatile flow, and it has a very small diastolic component here, and an area of flow reversal also in diastole. Where low resistance arterial flow, this is our low resistance flow right here, has a large diastolic component, and there's no flow reversal in early diastole. And low resistance flow is for organs that have to have continuous flow going to them. So this is the brain, the kidneys, ovaries, testicles, that kind of thing. All these types of the body need constant flow going to them, so they're going to have that low resistance pattern, meaning the body's sending very little resistance to these vessels in order to keep the flow going towards them. So with low resistance flow, the flow is sustained throughout both systole and diastole with no flow areas of flow reversal. We also talk about the pattern of arterial flow, triphasic, biphasic, and monophasic. So for triphasic flow, you're going to have your rapid flow, antegrade flow in systole. And then in early diastole, you're going to have a reversal of flow. This means it's going to go below the baseline. And then you're going to have a small antegrade flow in late diastole. So if this was, systole and this is diastole, that represents the flow to triphasic pattern. Biphasic pattern, you're going to lose some of this diastolic component. So it's missing your late diastolic forward flow. So you're going to have your rapid antegrade flow in systole. You're going to have that reversal flow, but then you're going to have Doppler silence. It's not going to come back up above the baseline. Monophasic flow. So this is you're going to have your rapid antegrade flow in systole, and then you're going to come down and have slow antegrade flow in diastole. You're never going to have that reversal of flow. Flow is always going to stay above the baseline. This is your antegrade flow. No reversal of flow in early diastole. So you'll notice this is our more high resistance pattern, and this is our more low resistance pattern. Veins. Veins have 5 characteristics to them on ultrasound, and veins are the vessels that carry the deoxygenated blood from all over the body. They collect it and then bring it back to the heart. There's the 5 characteristics are spontaneity, non-pulsatility, phasicity, augmentation, and compressibility. Generally, venous flow is below the baseline, retrograde flow, and it's spontaneous. So what does spontaneous mean? So spontaneous means the flow just happens. You don't have to squeeze a vessel to make the flow go anywhere. It occurs by itself with no external stimuli. If you don't have spontaneous flow, this can indicate an obstruction, such as a thrombus in the vessel. Non-pulsatility. So most veins are non-pulsatile. So they have a very characteristic pattern like this. They vary with respiration. When they're more pulsatile, you'll start seeing these peaks. Pulsatile signal in a vein can be a signal of an abnormal flow pattern, unless the vein is close to the heart. The closer the vein is to the heart, it starts to pick up a little bit of the cardiac contractions, signals from the heart, and you start to get a little bit more of a pulsatile waveform pattern. Phasicity. So this is the normal flow pattern for a vein, and this is a blood flow pattern that varies with respiration. So the waveform is going to go up and down, accelerate and decelerate in response to breathing, to inhalation and exhalation. Augmentation. So this is where when you squeeze a limb or a part of the body below the area that you're looking at, you should get this rush of blood flow that's visible on the spectral waveform tracing. This is what it looks like. So here's your normal pattern, and then you squeeze and get this rush of blood flow. If you squeeze and get a rush of blood flow, you know that vessel is open or patent. If you don't get this rush of blood flow, which we call augmentation, that vessel is not open. And then the last thing to know about veins is they should be compressible. So normal veins have thin walls, so when you push on them, they collapse very easily. What you do is you go in a transverse plane and then compress on the vessel. It should easily compress. Veins that don't compress or only partially compress, it indicates there's probably some sort of thrombus in those vessels. So why do we need to know all this about arteries and veins? In order to do our job as a breast sonographer, we have to have the basics down as far as artery and veins and spectral Doppler and color Doppler and power Doppler, because this will help us interrogate the arteries and veins that are in the breast and also in the axilla when we need to. We use them as landmarks sometimes. Also, it will help us interpret the blood flow patterns that we see within masses. So that's why we have to go through and just learn the basics. All right, so now we're going to talk about some advanced ultrasound machine controls. The first one is Harmonics. Harmonics is a control on the ultrasound machine. It's either on or it's turned off. So when you turn Harmonics on, it reduces noise in the image. This is the extra echoes that don't belong to a structure in the body, and it gives you a crisper image with reduced image artifacts. And Harmonics, the frequency that's sent out into the tissue is sent out at one strength, and then but when the signal comes back, it's received at double the frequency. And whenever we double our frequency, we know that a higher frequency gives us a better resolution. So Harmonics basically increases the resolution that we're going to have. But because we're dealing with double the frequency, it also decreases the amount of penetration that we have. There's several names for this. Most commonly, you guys will see CHI, coded harmonic imaging. This is simply the name for the GE machine. That's what we're going to be using in the lab, so that's why I teach you those abbreviations. You may also hear it called THI, tissue harmonic imaging, or simply just Harmonics. It's going to have a different name depending on what machine that you have, but the basic ultrasound control is the same. Compound imaging. And this is another control on an ultrasound machine. And compound imaging on some machines is either just on or off. On some machines, you can actually choose the level of compound imaging, so it can be set high, mid, or low. And what compound imaging does is it combines 3 or more frames. So a frame is one ultrasound image, and they combines them from different steering angles here, and meshes it all into a single image. So this creates a smoother image. It eliminates artifacts. The hard thing with this, though, in breast imaging especially, is if you have this set onto too high of a range, important artifacts that we need to interpret breast ultrasound images, such as shadowing and enhancement, or subtle findings in the breast, can be kind of averaged or smoothed out of the pictures. And you'll hear this control called crossbeam on the GE machines. Other things it's called is sono-CT, spatial compounding, or just simply compound imaging. Dynamic range. This is also called compression. This is a control in an ultrasound machine. It increases or decreases the number of shades of gray that are displayed by the ultrasound machine. It's measured in decibels. So if you have a wide range or a high decibel range number, you're going to have more shades of gray, which is going to give you a smoother image with less contrast. You have a small narrow range or a low decibel number of dynamic range, you're going to have a decreased number of shades of gray, higher contrast image, less grays, so more blacks and whites. So this would be our narrow range dynamic range. This would be our high range dynamic range. So for breast imaging and most types of imaging, we kind of want to be smack dab in the middle. Too high and too low gives us kind of a picture with less information. SRI. This is our speckle reduction imaging. Speckle is noise that is on an ultrasound image. These are extraneous echoes or pixels that don't actually correspond to actual structures in the body. And so they're the bright pixelated dots within an ultrasound image. And speckle is actually what gives our ultrasound image its texture. So this is what lets liver looks textured and lets organ looks textured. So SRI is a control in an ultrasound machine that increases or decreases the amount of speckle or noise in the image. So if it's set too high, your image is going to be very smooth. It's going to eliminate subtle findings. If it's set too low, the image is going to become too speckled, really speckly. So it's going to make it hard to detect subtle findings. So as with dynamic range, we want our SRI to be somewhere in the middle. Dual screen. This is another control on an ultrasound machine, allowing the ultrasound image to be split into 2 or sometimes 4. And so here's our ultrasound image, and you can see there's 2 sides of the image. So dual screen allows you to bring up one side at a time. Often in breast imaging, it's so that you can take measurements in 2 different planes and have them both on the screen at the same time, or see an area with and without color Doppler. So this is useful for various things. And also, when we get into elastography next quarter, this elastography uses dual screen. Panoramic imaging. This is called Seascape on our GE machines. This is a control on an ultrasound machine. And what it does is it provides a large field of view. So our normal field of view is just, small like that, but this knits a whole bunch of frames side by side next to each other, providing a huge field of view overall, and that lets us measure large things. Frame average, or also known as persistence. This is where you have multiple frames or images averaged or combined into a single image. It's different than compound imaging in that they're not taken from different steering angles. It's just taking multiple normal frames and just meshing them all together. When the frames are averaged together, there's more pixels per image, so you're going to have a greater image detail. So you're going to have a smoother image, a reduced noise, and this is also a method used of speckle reduction to get rid of all those extraneous echoes. So a low setting is going to have less image detail, more speckle. High setting is going to have greater image detail, a smoother image, less speckle. On many machines, frame average is not only a grayscale setting, but you can also use it within power and color Doppler. And this just averages the color Doppler frames together. Rejection. This is a method of reducing image noise. So the ultrasound machine will set a threshold, and below that threshold, the signal is not going to get displayed. So in order for an echo to get processed by the ultrasound machine, it's going to have a certain minimum amplitude. So this kind of acts as a filter. It rejects all the signals below a certain threshold, and rejects those weaker signals. So if reject is set too high, you're going to have a huge amount of signals that are eliminated. Although reject is really good at cleaning up the image, so only your strong signals are displayed. If you have a low setting, you're going to have less detail, a smoother image, but you will have increased penetration ability. And you also see less contrast between tissues. High setting is going to be greater tissue detail, more contrast between tissue, but less penetration. So with the other controls, use everything in moderation. It's not really good on an ultrasound machine unless you're trying to see something specific to have any of these controls be too high or too low. We usually want something in the middle. Line density. This is the number of scan lines that compile an image. So remember that the sound wave goes into the tissue and returns, and you get a dot of information for each echo. And these dots of information get built up, and all those dots turn into one line of information. And the ultrasound image is made up of multiple lines of information, and all these lines together, these are our scan lines, comprise the ultrasound image. When we increase our line density, we're going to have more scan lines. We're going to have a higher resolution, although it is going to decrease our frame rate and have more image detail. It's going to be higher contrast. When we have decreased line density, we're going to have decreased resolution, although you will have an increased frame rate, less image detail, and a smoother image. Suppression. This suppresses the noise in an image, which is a motion artifact, mostly. Some of the noises. A low setting, you're going to have a smoother image, less detail, less contrast, more gray colors. High setting, exactly the opposite. That image is going to be less smooth, higher contrast between different structures. You can delineate between different tissues better, and more speckle. So again, moderation, you want these settings to generally be somewhere in the middle, not too high or not too low. Edge and hand. So this is where the ultrasound machine combines adjacent signals, so adjacent echoes, and it lets us see the edges of structures better. So there's going to be a higher contrast between different structures and different types of tissue, and can really bring out subtle tissue differences and boundaries of a mass. So low setting, you're going to have less detail, less border detail, less tissue contrast. It's going to be a smoother image. High setting, more contrast, a greater delineation between the tissues, sharper borders of a mass, and more speckle. Auto optimize. So this is a button on an ultrasound machine that we can press. And this is where the machine will automatically optimize the brightness and contrast settings. So it adjusts your Grayscale Maps, that type of stuff, to give you a really pretty picture. We can also press auto optimize when we have color Doppler or spectral Doppler on, and the machine will automatically optimize the settings for you. And sometimes when it optimizes settings, you turn out with a perfect picture. Sometimes you press it and it's not all that helpful, but it's a button to keep in mind. Sometimes you hit it and it does a lot of the work for you. Text on the side of the ultrasound monitor. So I just pulled up our GE monitor here at Bellevue College. Obviously, whatever ultrasound machine you use is going to have different text on the side of the machine, but it's really important to know what this text means. So we'll just go over Bellevue's GE machine because that's what you guys will be using here in the lab. But if you have a different ultrasound machine that you're going to be using, look at the text on the side of the machine and familiarize yourself with this, because this is a quick way to look at some of the settings that you're on. So on the GE machine, FR is the first text, and this is the frame rate, so it's listing the current frame rate that you're at. AO percentage, this is our current output power percentage. SOS, that means speed of sound. So this lists the current propagation speed of the sound wave through the tissue. CHI is our harmonics, coded harmonic imaging. This lets us know if harmonics is on or off currently. FRQ is frequency. This is the current frequency that the transducer is transmitting at. Gain, this is how high or low our gain setting is for grayscale. And then you have something called S/A. Whenever you have a control that has a slash in the middle of it, this means that each side of the control represents a different ultrasound machine control. So in this case, S is the SRI control, and A is the frame average control. So when we press the adjust the SRI control, this number on this side of the slash is going to change. And when we adjust the frame average control, this number here on this side of the slash is going to change. So they often lump together controls that are, have similar effect on the image because it's an easier way to kind of control one thing all at once. So next control, depth. So this lists the current depth in centimeters that you are currently penetrating to. You can also determine this by looking at the depth map on the side of the screen. And then dynamic range, DR, is our last text on the side of the screen. This lists the current dynamic range setting on the machine. All right, so ultrasound safety and bioeffects. Ultrasound bioeffects. So a bioeffect is the potential harmful effect on the body due to the interaction of the sound waves with the tissues in the body. There's two categories, thermal, which is TI, and non-thermal, which is MI. And most of the time we care about this when imaging the fetus or the baby, but important to just kind of keep in the back of your mind. So thermal bioeffects, this is our TI, thermal index. There's three types of TI, TIS, TIB, and TIC, and these all have to do with the level when imaging different things, such as soft tissue or near bone, etc. Ultrasound controls that are going to affect the mechanical index, the MI, and the thermal index, the TI, are going to be output power, your Doppler controls, frequency, and your focal zones. The free controls, so these are not going to affect the MR or the TI settings. This is going to be our gain, TGC, dynamic range, any controls that are post-processing controls, or controls that are manipulated when the image is frozen, and also our depth. Non-thermal bioeffects. So this is our mechanical index. So this measures what levels at which cavitation is possible. And what cavitation is, basically, it's ultrasound waves have areas of high and low pressure. This is our compression and our rarefaction. And these increases and decreases in pressure. It can cause micro gas bubbles to form, expand, shrink, and then potentially collapse. And the collapse of these bubbles creates shock waves, and this is known as cavitation. So this has the potential, if MI is set to very high levels, to induce hemorrhage in the tissue, especially in lung tissue in the fetus. Cavitation is most likely to occur at low frequencies, where you're using increased penetration. The most serious type of cavitation is transient cavitation. So there's two types, stable cavitation and transient cavitation. ALERA. This is one of the most important things that a sonographer can know. This is our ultrasound safety principle, and it's known as ALERA, which stands for as low as reasonably achievable. And what this means is when a sonographer is adjusting controls, we should always be paying attention to what is our MI, what is our TI. These are things that are at the top, listed at the top of an ultrasound monitor. It tells us what they are. And also, we should be looking at what our output power control is. And we want to always minimize to the patient the risk of thermal effects or non-thermal effects of ultrasound, bioeffects. And even though the risk is incredibly low and we care about it more usually with the fetus, we always want to minimize to the patient any potential issues or problems that could happen. So when we're adjusting controls, we should always think about, does this control affect the patient? Does it affect the dose of ultrasound that the patient is going to get? If so, we want to use those controls sparingly and use controls more that don't have an effect on the dose of ultrasound to the patient. And then we also want to pay attention to the danger of electric shock. If you have a cracked outer portion of your transducer, if your outer transducer ever looks like that, do not place it on the patient. And every morning when you start scanning, you should look at your transducer to make sure that there's no cracks or holes in that transducer housing or outer covering of the transducer, because it can deliver a deadly electric shock to the patient. You can kill a patient with this. So if you notice any wear or tear or crack or damage in that transducer, please do not use that transducer.